Good afternoon. This is Kevin McGinnis. I'm here with Gary Wingrove from Mayo for the September 2019 edition of the Community Paramedicine Insights Forum, brought to you by the National Association of State EMS Officials, National Organization of State Offices of Rural Health, and the Center for Leadership, Innovation, and Research in EMS. This month we are going to have the program we tried to do last month that ran into some technical issues It's going to be a reprise of the 2019 International Roundtable on Community Paramedicine Conference, which was held earlier this year on Prince Edward Island in Canada. And helping us out with this is a well-known lecturer and EMS system leader from Down Under, a senior lecturer for the paramedicine program in the medical school at Australia's Griffith University. He was also a clinical director of the Mongolian Disaster Management and EMS Development Program and the academic lead of the Maldives Paramedic Skills Development Program. So I think we have a well-rounded, interesting speaker today, Duncan McConnell. Duncan, you want to take it away?
Thanks, Kevin. Now I have to live up to all that hype. Thank you for that. That's a big introduction. So thanks for joining me this afternoon. That's right, it is this afternoon for you. It's about 5 a.m. in the morning over here in Australia. So you've got me just out of bed. So Gary has asked me to sort of go through what we covered during our program in 2019 on PEI. So over the next 30 to 45 minutes, we're going to go through 2 days worth of conference presentations and topics, so you have a bit of an idea on where we went. There'll be plenty of time for questions and answers at the end. I'm more than happy to try and answer whatever questions I can. As was mentioned in the invite, you also do have access to all of the presentation slides via the IRCP website. So they're all up there if there are any particular presentations that you would like to have a look at. And the conference was recorded, and we can check with Gary at the end, but I believe he was in the process of chopping those up when we finished up, so we can find out where we're at with those. So if you do come across a particular topic, hopefully you'll be able to review that as well. Okay, so where were we? What did we do? Well, we're in beautiful Prince Edward Island in Canada. There was much lobster had. The island folk were very friendly. And apparently it had only stopped snowing approximately 10 days before we arrived. So for those of us that came from areas like Australia and New Zealand, where the parts where we live, snow is a rarity, we were sort of disappointed. But for all you Northern Hemisphere folk, I think considering how long winter was this year, many of you are very happy that the snow had gone. So I think one of the key messages that we learnt from this year's IRCP, and quite frankly, I think it's a key message you hear every year in IRCP, is that if you've seen one community paramedic program, you've seen one community paramedic program. Couldn't stress that enough. And in a recent trip that I've just come back from, Kevin alluded to that I work in Mongolia and the Maldives, I presented at a national symposium there, and they're looking at developing their paramedic system as well. So we had paramedic systems from all over the world talking about how they run ambulance services and work with paramedics. And I kind of borrowed Gary's little quote that he always says here and replaced the community paramedic program with paramedic and ambulance system. And it was exactly that. There was 4 different countries, and each country had their own representation of what an ambulance service and a paramedic service was, and each one was different. And I think that's a key thing associated with what we do here in IRCP when we have these conferences is we get to see multiple community paramedic programs, and we get to see how they're operated around the world, how they're different, how they're the same. But it clearly shows that we have a multitude of community paramedic programs we can all learn from, that we could implement within our own systems, or we could modify and adapt areas and systems that we see, or even put forward some proposals in locations where community paramedicine is yet to take hold. And these conferences really do provide you with a wealth of information that you can really take advantage of for your organisation. So if we sort of have a bit of a look-see at sort of countries discussed this year, we had Canada. They were our home and host country in this year's conference. We also had plenty of representations from the USA. There was, of course, a few presenters from Australia this year. I think we had 3 or 4 from memory. We also had a presentation from Turkey, and that was a new one for me. That's the first time I've seen Turkey discussed at IRCP, and that was quite interesting. The other area we also discussed too was developing countries. And the countries I discussed in that one was Mongolia and the Maldives. So yeah, those were the countries that we discussed, and it was quite an interesting discussion going through how community paramedicine was adopted throughout this process. So some of the areas that were covered and topics that were covered during our conference, and we'll go into more detail in these shortly. We looked at community paramedic programs in remote and Indigenous communities in Canada. And for me, it was personally, I thought that was quite a good insight into seeing how community paramedicine has been implemented in remote and Indigenous communities. I think it's an area, particularly I noticed here in Australia, where I think it could take off in quite a big way. So it was great seeing examples from Canada and how they're doing it. We saw my particular topic that was related to community paramedicine in developing countries, and I can talk a little bit more about that now because I've literally returned from one only about 4 days ago. We had systematic reviews of community paramedicine programs from around the world. We looked at limiting risks and providing patient-centered care. There was discussions about safety and keys to success with inpatient safety. We looked at different areas of assessment practices in community paramedicine and how that's evolving. Hospital at home for complex medical problems, and how that's benefiting our patients now with the introduction of community paramedicine. Then we went into the more academic approach. There was a few things there talking about science methodology and organisational redesign to improve community paramedicine programs. So using data, and for those people that are real data hungry and know the power of data to enable things to progress, that provided some good insights in that direction. We also looked at education of community paramedic programs in Alberta, Canada, and they focused on how they're approaching that there. We then sort of moved back to the East Coast, and we had that presentation from Nova Scotia with integrated health programs. We also had a discussion about a cost-benefit analysis on community paramedicine programs for low-income seniors. And ironically, actually, my auntie in Ontario was part of that program, and I was getting funny messages from her while we were in the the conference. Well, the presenter was on. She was sending me things through messages saying, "Hey, that's the group that came and looked after us." So that was kind of surreal. We also had a look at reviewing the frequent users of ambulance services and how community paramedicine is sort of leading the way in helping to reduce that, therefore enabling services to go in more urgent directions as opposed to being tied up with our frequent callers. And then there was a interesting discussion had by long-term presenter in IRCP, Peter O'Meara from down here in Australia, talking about paramedics and interprofessional practice. That was quite an interesting discussion. And then he also continued on with an interesting discussion focused around interprofessional tertiary education in rural environments, sort of multidisciplinary care and that type of stuff, and breaking down the silos in healthcare education. So that's a bit of a summary of all the topics. So what we're going to do now is we're just going to flick through a collection of slides which sort of highlight the key presenters or the key, all the topics and what they were discussed. So I'm not going to read them word for word out of the IRCP handbook. You can actually get all of these and more information from the handbook, which is available from the IRCP website. So just have a look under the 2019 program, and you'll be able to get a much more in-depth level. But I just want to touch on the key aspects and areas that each of these presentations actually provided. Because as I mentioned earlier, the beauty of our program, or the beauty of IRCP, is it really enables you to look at what other people are doing and benchmark your practice, or have a benchmark for practice if you're looking at implementing programs such as these within your own organisation. So one of the earlier ones we had came from McMaster's University, and this particular one focused on emerging health service delivery system utilising paramedics. So they did a range of healthcare visits and included visits to primary care physicians, and identified different types of programs to associate with this training. And this actually was the group that visited Miami, believe it or not. So this, they've been working with Hamilton Paramedic Service, I believe, and working in the various areas there and looking at different things. And they went into some of the old care or older adult group housing areas and set up shop inside the community areas or common areas, did health checks and connected people back with their GPs and other aspects like that, and identified some at-risk patients actually, and provided some intervention, which in many cases I found out later on actually did provide some assistance and help where if these patients had not been seen when they were, some may not have come out of hospital, and some had some actual health issues that they were completely and utterly unaware of. So they were able to get on top of that. So it's a great example of how getting into areas where people can't afford to get to a hospital, don't have transport to get to their own GP, or don't want to trouble an ambulance for a simple ailment, which they actually don't think, they don't really think they're all that sick. But when they're actually looked by a medical professional, it's actually identified you are a lot sicker than what you realise. So these type of programs have really lifted that up, and a good connection back into primary healthcare, and some good success stories are starting to come out of it. So the other one we had, this was from our home presenter from Island EMS. They were one of the sponsors for our 2019 presentation. And this one was to talk about high-risk call types and how they're becoming more common. So they presented on how they had a bit of a challenge with both patients and the EMS agency that served them, talking about the areas of Prince Edward Island and how they approached the management and quality management implementations and what they were doing, and talking about follow-up, and other aspects like that, and helping to explore the implications of patient health, satisfaction, and the program's ability to prevent transport and admissions to hospital for patients that didn't really need transport, but were managed quite well from some good at-home community care and community paramedic programs. The other one we had was one of the first few presentations by Peter, and this was also one related to our Global Paramedic Higher Education Council. So Peter was talking, actually he mentioned some of the work I'm doing in developing countries and the role of community paramedicine in that direction. And he really sort of hammered in and honed in on paramedic roles and how scopes are changing to meet the needs of population health today, focusing in a little bit on the paramedic practitioner and talking about career pathways and positions and integration within the healthcare system. And he gave some good examples in Australia, New Zealand, UK, Canada, and touched on some of the areas that are currently under development as well. So the next one that was discussed during day one was we had this one from Matthew Wetter that was from talking about common assessments in repeated patient encounters. So looking at a prospective cohort study intended to evaluate a standardised assessment instrument in community paramedicine home visits. And they looked at that across multiple Canadian paramedic services. So it wasn't just one service. They really brought in a collection. It was quite interesting to see how that was approached. And I think it brings back the mantra of IRCP. If you've seen one community paramedic program, you've seen one. And what they've done is they've taken multiple programs and they've assessed them in this light. So it shows a good way of looking at what others are doing, analysing the data, and looking at ways that we could implement or identify gaps in areas that we do and implement things that could help fill those gaps. So yeah, it was quite an interesting approach to that, and again, another one that's well worth a review if you're looking at doing some reviews and updates to your own programs within your own services. From another one that we've been moving across into Alberta, they looked at a hospital at home model for patients with complex medical conditions. So this was sort of brought apart by Alberta facing a health crisis with increase in seniors and over the age of 65 from 11% at present, and they're projecting an increase to 20% in 2031. So they're looking at some results from a home care case management study in Calgary and trying to work out the best emergency medical services management that they can utilise for these patients. So again, using some big data to work out the best ways they can approach patients with complex medical conditions so that they can sort of alleviate having to take all of these people into hospital. So it was interesting to see how people are sort of evaluating what we're doing now, but also putting practices in place now so that they can help tackle these future trends. From there, we moved into the Hamilton area. So they were looking at system planning and improvement for community paramedicine. And they talked about some of the areas that were discussed earlier that they're joined with McMaster's University with, and really discussing the several community paramedic initiatives, home visits, health clinics, remote patient monitoring, palliative care support, and social navigator programs, and demonstrating how that they're implementing this across the Hamilton Paramedic Service. So a common theme that we saw with a lot of our services that presented here, and it wasn't just limited to Canada or America it was limited. Pretty much all the countries presented this was the growth of the challenges we're facing within the pre-hospital space, and how we're sort of moving now on looking at how we can manage repeat callers, how we can reduce these numbers, and what can we implement, what practices can we apply in that context. And then we sort of moved into the education of community paramedics in Alberta. So they've looked at the challenges they've faced in that province and how they can increase the training and development for the Albertian community paramedics. They had 3 distinct but collaborative efforts to support the development of community paramedicine, and that was discussed throughout this presentation. They utilised qualitative interviews and experts to gain their perspective of what was done, and they identified some key areas of and gaps that they needed to provide to support these community paramedics. An interesting concept of this that I think rings true to people looking forward to ways that they can improve things that are currently in place was doing that gap analysis, looking what's currently there, identifying where they need to make some changes, and working with the key stakeholders to identify some ongoing education programs that the community paramedics there can actually benefit from. So the presentation concluded with them talking about how staff feedback, information from leadership, and upcoming program direction of where they're going has really made a big difference in ongoing professional development within this space. So it'll be interesting to see if there's a follow-up with that in future IRCPs, maybe in 2020, to see how they're going with that particular program. We also had some discussions here with advancing community paramedicine. This one sort of spoke more about emerging specialty roles and the scopes of paramedic practice being driven by demographic change, technological innovation, and evidence-based research. And it sort of touched on areas such as links between emergency medicine, critical care, public and community health, and necessitating the move from sort of the paramedic technician model towards a practitioner model, and how the migration has challenges as transition to new frameworks and other aspects like that. Because as we move away from a technician approach and we move to more a clinical thinker model, we're more starting to use the approach of clinical reasoning and clinical understanding as opposed to black and white algorithms. And autonomous problem solving and decision making. So that is a big shift. So this discussion was, in this presentation, sort of identified the challenges within that space, and quite interesting approach. So another area we spoke that presented, this is our Nova Scotia group. They talked about the Cape Breton community-based paramedic program and how they are serving that municipality. So the program sees patients referred to either a clinical support nurse, virtual visit, or a community paramedic home visit, or a combination of both. Referrals were generally generated by healthcare providers within the hospitals, with the goal of delivering supportive care to patients that are identified for this type of service, providing timely access to a unique clinical service within the Cape Breton community catchment. So yeah, it was interesting scope of sort of discussing how sort of hospitals and healthcare, everyone's sort of getting together, singing off the same song sheet to try and provide a unique clinical approach to their patients. So really nice sort of community engagement available there. And then we had some presentations here talking about how we can use, again, our big data with cost utility analysis of community paramedicine programs in low-income seniors. And any of you that work within those sort of senior management areas and you're looking at ways of saving money, these type of studies can really ratify what you're trying to achieve. And if you can show the potential incoming savings and then show examples of how other organisations have done it, both within your own country and around the world, it can really help you get some of these programs on board or help you expand your current programs. So this particular presentation really focused around showing significant decrease of expensive emergency services, but the overall cost utility of how doing these community paramedicine programs in low-income seniors compared to like your usual care in subsidised housing. So yeah, they really went into the big numbers and cost benefits here, and showed some interesting areas that look, unless you actually dug into the detail, you wouldn't have seen it. So another area we had was we had a few people talking about some of the palliative care initiatives, and there's been a bit of a growth in this. And from what I understand, in other areas that I heard outside of these presentations, was the amount of money that's been poured into palliative care programs in Canada, and it's absolutely beautiful to see this type of process starting to happen, with money being invested into this part of people's lives, because it's quite, those of you that have had experience in your own family with dealing with palliative care or some of the patients you've seen over the years, it is a sad and horrible thing to witness. But by having programs in place and having people being able to implement what the patients want and what's best for the families and other aspects like that, it's great to see paramedic services and ambulance services around the world, not just in Canada now, implementing some of these palliative programs. So this particular presentation was based on British Columbia Emergency Health Services and what they're doing within palliative care emergencies. And it was their approach of implementing palliative and end-of-life care. So they discussed things such as a standard of practice aligning with paramedics and patient goals to advance existing communication pathways and what was requested by the patient care team. And it was an add-on to their already successful community paramedic program. And yeah, really showed some how patients always, in that palliative sense, always prefer to be treated at home. It's a happier environment for them, and providing their program actually, BCEHS, actually provided some good training and development for their community paramedics in end-of-life care and education, and how they can manage that quite well, and showed examples of different drug therapy protocols, working with palliative teams from distance, using some telemedicine, talking about the sheer size of British Columbia, being 945,000 square kilometres. So working in ways of working through their secondary paramedic-led triage service, clinical oversight, and other aspects like that they've implemented across both their metropolitan and rural communities to improve the palliative care support for patients in BC. Okay, and then we sort of moved down to the Niagara area, and this was talking about some of the innovative ways that they're dealing with current and future healthcare needs of Niagara. They're getting a bigger population of older adults, areas where people are liking to retire. So they've seen a bit of an increase over the past sort of 10 to 15 years in areas where the population is aging, and as you get with an aging population, you get the various comorbidities and associated health conditions that an aging population brings with it. So they're looking at ways where they can be innovating and approach the future needs of this growing population type, so that they can meet the needs from a community paramedicine perspective, work well with their integrated healthcare system, and ensure that hospital services aren't overloaded with an increase of an older adult population. It was quite interesting how they're looking in the future and benchmarking on things now, and looking at ways to come up with key performance indicators so that they can measure to ensure that they're meeting what they're looking for, continued quality assurance and quality improvement, to work out how they're going to implement their new clinical response plan and work within this process moving forward into the future. Okay, so there was also a discussion about our second presentation from BC. They were talking about the patient-centred approach to primary care in rural and remote communities. And I really think we talk about how things work within metropolitan a lot, but really seeing how community paramedicine can work in rural and remote communities, I think, is a really big practice and a real shift away from our traditional sort of ambulance or paramedic approach. And just this particular presentation really focused on how community paramedicine is an innovative model for delivering primary health care, prevention and health promotion in rural and remote communities. Now, for our Canadian presenters and our US presenters, you're both in countries that are quite large, quite vast. There's a lot of distance. So having good, solid community paramedicine programs in rural and remote communities can really help enhance that community's healthcare system and really be a good extension of the way things currently operate. So it's a value add, I think, to any health system, particularly in the rural and remote communities. And then we had a discussion about paramedics providing palliative care at home in New Brunswick. So this there were a few presentations actually focused around the implementation of palliative care and how it is becoming a key part of community paramedics models. And this one focused on an in-depth look at innovative model of community-based palliative care provisions in New Brunswick. And it's working in collaboration with the palliative care areas within the hospitals. So real interdisciplinary approach, a lot of synergy among a diverse group of healthcare providers, and developing innovative patient and family experiences and increasing system effectiveness and efficiency, thus sustainability of the healthcare system for future generations. And again, it's really great seeing how palliative care has been incorporated across into our community paramedic models. And then we started to have a bit of a look at some case studies. So this was a nice approach at how programs are unique in certain service areas, and looking at case studies of what's worked, who will be there, what's happened, what have been the benefits to the health system, what are areas and gaps that we've still got, and looking at how the community paramedic program is able to be enhanced and developed further. With this one talking about Sedgwick County EMS. So they were looking at what other programs are doing internationally and nationally as well, and looking at ways they can improve their current services and build in greater capacity. And then we also had a bit of a discussion about the role of community paramedic programs within hospice. And that was interesting to see how they were discussing patients on hospice with advanced directive plans that's sort of not in line with the usual paramedic emergent protocols. So engaging with hospice agencies and manage patients and family issues surrounding end-of-life care. So yes, it was just a good example of how they're sort of moulding previous practices into future practices to better deal with how they can approach this or EMS-specific end-of-life protocols to enable paramedics to carry out at hospice orders and bridge care back to the hospice provider that's caring for them. So yeah, another interesting approach to some new areas that that community paramedicine has been adapted to. Okay, so we also then moved into some assessment studies. One from Krista. She was Western University, so fellow Australian presenting here. This was to talk about health resilience assessment of dealing with frequent users of the Canadian Emergency Service System and how this tool can align to paramedic prescribed interventions to improve healthcare resilience. So having a look at the disadvantaged populations with poor access to healthcare and discussing how community paramedics have been uniquely positioned to identify barriers and boundaries and become enablers in accessing the care pathways or health resources for these particular patient types. So she touched on areas such as implementing strategies and improving resilience for community paramedicine at home program, and how they've conducted some randomised trials, again with McMaster's University, and working through ways that they can really enable and make this nice and sustainable. So it's still in its infancy, its development. So far to date, they've done 58 unique participants that have undergone the assessments. Mean age was around 72, and actually the bulk of them were about 58% were females. So they're and some of those people have been now put forward in identified referral pathways and integrating a range of social and personal elements of health not traditionally found in more clinically focused referral algorithms. So really looking at taking a different approach to looking at people's needs and seeing how they can change them for the better of the patient. So keeping on our Australian presenters, we had Buck Reid, also from Western Sydney University, who was blown away by the fact that he could present and have his presentation translated immediately into French. We were all quite impressed when Buck tried to see how good the French translation was for Australian slang. Ironically, there was just this big blank space that came across the bottom of the screen as he tried a few Australian slang words. But Buck's presentation was focused around paramedics and interprofessional practice, so balancing autonomy and collegiality. So really touching on how community paramedicine has become quite collaborative within other areas of healthcare, and how continued growth within this space really enables quite a benefit, not just to the healthcare system, but to the patients that have been affected and their healthcare access improved in this area. And touching on areas where we've stepped away from the more traditional concepts and expanding on areas of increased autonomy, education and diverse practice roles. And pulling examples from other areas around the world and trying to break down some of these rigid boundaries and rigid constraints of professional identity. And it's great to see aspects of this really starting to take hold around the world today. And then we had, and sort of following on from that, we had another presentation that sort of focused around interprofessional tertiary education in rural environments to sort of enhance multidisciplinary care in future practice. So breaking down the silos in healthcare education. So this one focused in rural training education areas, like US and like Canada. Australia has a massive amount of rural locations, with our average distance between sort of major towns and rural locations anywhere from 1.5 to 2 hours minimum. Not uncommon at all to have a 3 to 4 hour drive. I know in my experience working in rural and remote areas, I actually stopped driving to many of the locations, and I actually flew because one of the locations we visited quite regularly, it was an 8 hour drive each way to get to this particular rural environment. So it was easier for me just to jump in an aircraft and fly myself out. So the beauty of these interprofessional relationships, and I had experience with my rural life working in these spaces too, is taking these silos where you have doctor, where you have nurse, where you have paramedic, and just obliterating them and working towards ways that we can work together as one and become one systematic healthcare team for our rural health environment. And Christy touched on how Western Sydney University is implementing such a collaborative approach through interprofessional cooperation. And it's really great to see how now paramedicine is starting to emerge and stand on its own 2 feet. Because granted, we've only been around for about 50 years when you think about it. The 1970s is really when we started to take off. And medicine and nursing has been around for hundreds of years. It really shows that we're now starting to get that recognition through the professional practice, through our degree entry to practice and these programs. And people are starting to see just the difference of what we do versus what happens in a hospital, and how that these old silos from years past need to be broken down so that we can enhance our own clinical development, our own interprofessional ability to train and develop and work together. So, yeah, it was a really nice touch on how this is working in a location and providing examples of how other people can follow. We then had an interesting discussion about approaches to clinical history taking in community paramedicine and how that's evolving. This one focused on 4 frames of approaching to clinical history. And this was taken from the School of Medicine, the Warwick School of Medicine, in the United Kingdom. And what's been done for their community paramedic students from emergency ambulance service paradigm into community and clinic areas. So it was interesting. The 4 pillars sort of focused on 4 frames: presenting complaint, past medical history, allergies, drugs, social, family history, concerns and experiences of the patient, and working towards how they change their approach in providing this development. And then they sort of continued on from that by looking at an evidence-based approach as a way of constructing a postgraduate remote and community area paramedicine practitioner program. So using the evidence that they've gathered over the years to produce some new training and development moving forward in our education and development of community paramedics in that area. Another area that we discussed was to do with community paramedicine in remote patient monitoring and evaluation. So making use of telemedicine, using other aspects for long distance locations and how we can evolve, particularly in remote locations that can take 2 or 3 hours to get to per patient, and integrating some of these patients with Bluetooth-enabled devices, receivers associated with specific health conditions such as scales, blood pressure monitors, heart rate monitors, glucometers, that connects to the community paramedic team via via a portal and connects with their health practitioners as well. It looks at ways that they can monitor sort of plans and processes in place, and really sort of enhancing or looking at the next direction of digital healthcare monitoring programs, and looking at ways that we can use that to enhance and support diverse patient cohorts. And I think in particularly the remote locations, I think this provides a great way for patients with chronic illness to be able to be connected with both their GPs or general practitioners and the community paramedics in that area, so that they can feel safe at home and out of hospital. And if there are some areas that flag up or pop up that are concerned for their health practitioners, then either the community paramedic can go and pay a visit, or an ambulance can be sent out to do an assessment, potentially bring them into hospital, but give the patient a new level of connectivity. And in today's modern approach, with what's available to us, really the future and where we can go with this digital monitoring is really only limited to your imagination and how much money you have in producing these programs. And it's a real innovative and future area of growth I think we're going to see a lot more from in the future. So another area that was discussed too was we were looking at areas of improving health of the 62 million people who call rural America home. I've mentioned earlier before already today that rural health is a big area, and there's lots of space. Okay, so this one sort of discussed on areas within the US of potential future of rural health, possible role of EMS and community paramedicine programs in rural America, and how the National Rural Health Association is working towards developments in this space and what they can do for people in rural communities. We also had a discussion here on frailty screening and assessment for community paramedics. So looking at evidence on frailty screening, assessment and outcomes, and how community paramedics can help identify areas in this space. And it's sort of like treat in place, treat and refer pathways, increasing the knowledge of frailty to community paramedics and identifying areas where they can really apply aspects of counselling the patients and family on frailty and discuss mitigation strategies, highlighting prevention services and ultimately slowing the progression and increasing patient mobility and quality of life, and helping prevent future independent loss. Which, let's face it, if we can keep people in their homes longer and make them feel safe about being in their home without the risk of falls and other aspects like that, it increases their ability and quality of life. And let's face it, no one likes being taken out of their home and sent to hospital. I mean, hospitals, they're nice, but let's face it, everyone would rather stay at home as opposed to a hospital. Even going through the emergency department, you've got the risk of a patient contracting something, no matter how clean we keep it. So enabling programs like this where we can sort of help decrease people presenting to the emergency department, I think that's a key part of community paramedicine, looking at alternate ways and pathways that we can present for our patients so that they can stay home or they can connect with their local practitioner as opposed to jumping in an ambulance and motoring their way into hospital. Then we had a nice presentation here from reporting and evaluating community paramedicine in Ontario. So looking at standards of program delivery and monitoring and evaluation and reporting on the overall efforts of community paramedicine within Ontario, and looking at ways that they can improve existing local health integration networks, and working alongside with the Ontario Association of Paramedic Chiefs to ensure a broad representation within this space, and looking at ways they can increase collaboration, partnerships, particularly within primary care, that can lead to the prevention of hospitalisation, improved patient experiences as they sort of transfer from that acute care setting back into the community. So another example of provincial involvement in sort of spreading the word outright. And then we had a, whoops, I've jumped too many slides. And then we had a discussion of perspectives of frontline of 2 North American community paramedic programs. This is another presentation done by Peter. And sort of looking at how, taking a couple of programs, looking at the primary care and public health service provision and proactive engagement of paramedics in preventative care, chronic disease management. So this study sort of addressed motivations, job satisfaction, challenges from a perspective of community paramedicine, and looking at the pioneering of 2 independent programs in North America, and then using an observational approach to acquire quantitative data, through informal discussions, semi-structured interviews, focus groups, and direct observations of practice. And then looking at areas of how they identifying gaps and how they can improve current practices and procedures, and moving forward in enhancing the current program that were in place. So another example of just not implementing a community paramedic program, but looking at what's in place, looking at what's been done, identifying the gaps and the needs, and coming up with ways in which they can enhance that and build on those to make the health system a much more approachable way. So I think this slide sums up community paramedicine quite well. The only thing that would sum this up even better would be a picture of MacGyver, and I'm pretty sure this presentation had that. So this is the old Swiss Army knife, where basically as a community paramedic, we try to have a tool for whatever presents us, and that how community paramedic programs are an integral role in filling the gaps within the current healthcare system. In particular, they touched again on Indigenous healthcare communities and First Nation healthcare areas where they're integrating aspects of paramedicine into primary healthcare and working in traditional roles and embracing new roles of community paramedicine in rural and remote and isolated Indigenous communities. But yes, I really do think the old Swiss Army knife really sort of touches on paramedics in general. And then this is a really huge Swiss Army knife, so that sort of is adding on the additional benefits and categories that the role of community paramedicine can play in enhancing healthcare service delivery, that next step. So we've added on a few more tools and tricks to our Swiss Army knife to provide additional cares and development for our patients. And then we had my discussion on talking about community paramedicine in developing countries and how that is changing the face of healthcare delivery within these particular countries. Now, we're still in the infancy of development in both locations. Mongolia is somewhere I've just recently come back from, and their ambulance system, well, they actually have an established ambulance system. It's physician-based. However, the training and development of some of the physicians that end up in their ambulances are generally fresh out of university, so they're fresh graduates. So no training or development of pre-hospital care, a head full of knowledge of a 5-year medical degree, but then trying to apply said medical degree with patients in the pre-hospital setting. You can see how that can be quite a challenge for both the doctors and for the care delivered to the patients. Now, in saying that, the process they have in place at the moment for the experienced doctors who are sort of working in the pre-hospital space is actually quite interesting, because they apply many aspects of the community paramedic model that we're looking at developing, and many countries do have developed already. So in a recent trip that I just did working on road, I did a few shifts with them. We were doing suturing on the side of the road. We were prescribing antibiotics. We were moving forward in various sort of treat and leave perspectives. So implementing some good aspects of primary healthcare on the side of the road and in people's houses, and then moving on to various other aspects of community and primary care. And that's their daily shifts. They do 24-hour shifts, so 24 hours on, 72 hours off. They are grossly under-resourced in both equipment and people being able to respond. Your ambulance gets 23 litres of diesel, and if you run out of diesel during your 24-hour shift, then a tow truck comes and tows it back to the ambulance station. So there's some significant challenges there, and we're in the process of developing some enhanced processes and training for both physicians and implementing a paramedic development pathway from both paramedics and a physician-based response. And just like the US and Canada and Australia, they have significant rural challenges. They've got 1.5 million people in Mongolia within the capital. The other 1.5 million are scattered without their rural and remote locations. And at present, there's actually no aeromedical services. So it's a country that's about the size of Canada. Canada's probably a little bit bigger in length. But if you look at the provisions we have in place in somewhere like Canada or the US with aeromedical retrieval for long distances, well, they don't have that at all. So what would probably take us about 60 minutes in an aircraft to get someone back to a major tertiary institution could take them up to 5 or 6 hours across, well, they're roads, but if you saw what they classified as roads, you'd shake your head. So the Maldives is another interesting location. This is a greenfield development. They don't actually have an ambulance service implemented. They're in the process of implementing that. And the beauty of that is we've identified a key group of individuals that are more qualified than a nurse, not quite qualified as a doctor. They're called primary healthcare workers. They're no longer working in the capacity they used to, but they actually had prescribing rights and other aspects like that. So we've developed a postgraduate diploma to over 1 year of accelerated training to turn these primary healthcare workers into community paramedics and base them across the 26 different atoll health services within the Maldives so that they can extend the reach of the healthcare services or atoll health island services and work in that community paramedicine model and go out and dispense, go out and do areas that will save the patient travelling 4 hours by boat to get to a hospital and health centre. Look at different approaches. So looking at what's some of the best models and approaches that we've seen through the past sort of 15 years of IRCP and what other people are doing and seeing how we can adapt some of those best practices into implementations of models there. Now, we're also developing your standard level of paramedic education development as well. But these primary healthcare workers, with their background, provides a real niche level of paramedic development within this developing country, and really providing a level of care that the citizens of the Maldives have never had. So, yeah, it's some really interesting developments in this space, and I hope to present more on them in the future. So just reiterating on what I said at the start, again, if you've seen one community paramedic program, you've seen one community paramedic program. And I think based on those 30 slides that we've just sort of gone through that touched on the bulk of the presentations that were covered during the PEI IRCP conference. And again, I know they were all a little bit rushed, but gave a bit of an overview on what we touched on and what we discussed. And it really comes back to this statement that you really have only seen one community paramedic program. So what did we take home So at the end of every IRCP, we always have a sit down and we have a bit of a chat. And being a FOG, or a friend of Gary, I was given the task of taking down the notes of take-home points. So these have been published on the website as well. But the key ones that were identified throughout this program was that people are publishing their results, and their results are being noticed for the next generation of community paramedic programs. How many fantastic community paramedic programs there are out there and what people can build off. The key areas of learning from other regions and how they implemented new systems in EMS and community paramedicine. Validating how we're making a difference in this place, one patient and one process at a time. And encouraging to see the number of people involved in palliative care programs. And that was one thing that did stand out. There was a magnitude of palliative care programs identified, and this was also identified in the Paramedic Chiefs Conference that was held before IRCP. Reframing the conversation of how we change into professional services around the world. And it's nice to see that these programs are sort of stepping into developing countries and other countries as well. And it's not just focused in a couple of areas like initially was. Now we're seeing it starting to be spread out worldwide. Also, the impact community paramedicine programs have on the community. And regardless of the countries and cultures, we're all dealing with the same problems. And as I mentioned earlier, as a FOG, I get to be Gary's note taker at the end of IRCP. So looking forward into 2020, we've got the UK in March of 2020, and watch this space potentially for October in the US. Gary can talk more about that shortly, but definitely our next main meeting for those that can attend will be in UK in March in 2020. So that is it from me as I sort of push through the 2 days worth of presentations in a space of about 40 minutes. I apologise if it was a little rushed. Very happy to ask any questions that people might have before we finish up today. And again, thank you for spending the time with me this afternoon listening to what we've been up to. Over to you, Gary.
All right, everyone. Kevin has lost both internet and cell phone at his place in Maine, so he's no longer with us. We're going to unmute your lines, and then we'll do question and answer time. Let me first address the previous slide that Duncan had, this one, and say the UK does their meeting in March, which puts us a little bit off cycle because the rest of the countries we rotate through all have their meetings sometime between June and October. And so going in March potentially leads us to a year and a half before our next meeting. So the last time this happened, we did 2 meetings. We had one in the UK in March and another one in the US in October, November. So we're thinking about that for this year, but that's not settled yet. So if you can possibly make it to the UK in March, that would be a good thing to do. I'm going to unmute everybody's line, and Jonathan has his hand raised, so we'll let him start with questions.
The conference has been unmuted.
Hi, can you hear me?
Yes, go ahead, Jonathan.
Yep.
Hello. Duncan McConnell, professor, long time no talk.
Don't promote me just yet.
So I will ask just 2 questions, and I'll ask them both, I guess, and then take them how you will. Obviously, like you said, you covered a ton of stuff. So the first one, you discussed palliative care on a number of slides. Is there an equivalent to the pulse form, which is known as either the portable or physicians, depending on where you are, portable or physicians order for life-sustaining treatment that are being used internationally? So the pulse is sort of an emerging physician-ordered advanced directive, kind of a summary of it here that's sort of spreading out across the country in terms of informing EMS and other stakeholders of patients' wishes. I'm wondering what, if anything, is being done in other places. And the second question on this one, I suppose, is a little solicitous because it's coming from me, but you mentioned that some of the presentations were data-centric in particular. You mentioned, I believe there was one from Ontario. I think you said that was very much about reporting. So I'm very curious, and I've always been curious as to what these departments are using to track the data that they're using to report. And the reason being that I know in particular Canada and I think other emerging markets, their data requirements for pre-hospital care in general are less rigid than NEMSIS. They have been in general less controlled in their emergence. So what kind of commonality, common data sets, or apples-to-apples analytics are being captured across these countries so that when you look at the different programs, you are, you mentioned Swiss Army knife, making sure that the Swiss Army knives have, some of the same tools in them and that we're doing lateral comparisons as opposed to, I guess, getting away from the idea that one CP program is one CP program, or have we not done that yet? And so those are the two main questions. Thank you so much.
No worries. So I can answer the first one pretty quickly. I know from an Australian perspective that we have what would be the equivalent to what you were mentioning, advanced health directories. We have those here as well. So these are legal documents that generally before the patient gets to a point where they've lost the ability to make decisions for themselves, otherwise it goes to their power of attorney, where they can put those exact things down. So if they're presented to a paramedic, community paramedic, or someone within that field, they see that and then they just follow the patient's wishes.
So these
Yep.
So am I muted? I didn't know if I was muted again. These are actually not, so it's not an advanced directive. The advanced directive, as you say, is a legal document. This is a medical document. So wondering whether where the physicians are the ones essentially saying, you mentioned hospice, and so it's coming up in context where folks are older and frail, and basically the physicians are saying in consultation with the with the patient, we've decided that we're not going to, take heroic measures or whatever it is. But the difference here stateside has been that that's sitting on the medical side as opposed to on the legal side. I'm wondering if you're encountering that in these programs yet.
No, well, here I can only really speak for Australia in that context because we'll need someone from the States to speak about that. But here it's medical and legal, so the form is created from a legal perspective. However, it is filled out by a medical practitioner. So the legal perspective is really just to cover the arse of the doctor and to say that we have discussed this and we are I am the medical professional. I agree with the patient's wishes. The patient and the family agree with the patient's wishes, and yada yada yada. So yeah, we might need to, as far as states in Canada and other countries, we'd probably need people in those areas to discuss that. But from our perspective, that's where that sits at the moment. As far as the other one with your data, not 100% certain for the exact response with that, because every ambulance service is slightly different on how they allow you to access data. I can tell you many a story about people that have done research in Australia where they've started off really well with an ambulance service and then they encounter something that the ambulance service didn't know existed and then block further use of data or the ability to publish the data. So yeah, that's I don't have an answer for your second question, I'm afraid.
Well,
I don't think it's apples for apples.
You say you do or you don't?
Well, all of ours are. We don't have like a NEMSIS system or anything like that over here. We're more. Every ambulance service in Australia has a different level of gathering data. So although we gather things such as basic patient information, how that's stored and how it's released is very different. What I saw from the presentations, and remember I didn't give presentations on big data, that was just what I remembered. What I saw there, those that spoke in Canada about the Canadian programs tended to have similar data sets And Peter's presentation when he was examining those two North American programs, they also seem to have very similar data sets. So from what I saw with the big ones, those discussed about data sets in America seem to be using similar data sets as those that discuss data sets in Canada seem to be having similar data sets. So, I guess it really depends on what location you're on, what access you have to the type of data you can read from.
Right. Did the topic come up? So at the National Association of State EMS Officials conference this past year here, there was a fairly robust cry out for the need to move in the direction of a homogeneous data set. Where at least on some level, right? I mean, you can always have local customization, but the idea that there would be at least an 80-20 or something where people knew officially what they were going to be documenting. Has that outcry become an international call yet? Or is it, again, sort of unofficial in terms of people are gravitating, but they're not being required by any means to look at the same things?
I don't know. I think unofficially, when we want to compare apples to apples and we're looking across different countries and different jurisdictions, I think we try to gather similar things, so as in demographics, conditions, medications, that type of stuff. Like the standard thing you'd probably see on every EPCR if you wanted to try and standardise stuff. I think that is the area that would be standardised. What sort of did stand out in the presentations that were held in June is that there was a bit of a focus on seniors of lower income. There was a focus on PAL care. There was a focus on future developments of current CP programs and what direction we needed to go, and also the ageing population. So they all had similar areas that they looked at. So I guess maybe you could say there seems to be an unofficial set of areas that people seem to look at to sort of help with this. But I see your point. There is no official set data set that you would all compare no matter where you were. And I can see the benefit of having such a set standard because it would make some of these comparisons a lot easier.
Well, it would strike me that this is kind of the perfect group, right? I mean, either, at an IRCP, for example, to kind of have a whiteboard up and start that work. You got people from all over the place in the same location. So wonder maybe that's something that Gary can speak to, but at a future event, I mean, it seems like something that would be worthwhile. I mean, if everybody's talking about what they're reporting, at some point sort of throw the data sets up on the wall and say, here's what we're actually reporting on. It may turn out that there's quite a bit of overlap already. It's sort of not being expressed because you're reading the digests, right, as opposed to actually getting into the data set once you're in this presentation. But it would be really, really nice to know at what level of granularity there is that overlap and where there isn't. And then those types of efforts are happening here now to sort of, come up with see what is happening in different states and how different are they really. Because, as you say, one program is one program, but if it turns out they're 85% overlapped, we're a lot closer to a common thread than we think. So anyway, thank you so much.
Yeah, fair enough. No worries.
Any other questions for Duncan? All right. Well, thanks everybody for joining us today. I'm not quite sure what Kevin has planned for next month, but I'm sure he'll let us all know soon. And the recording of this one will be posted on the Paramedic Foundation's YouTube channel later today, and also a link provided in the archive section on the CPIF website. Thanks for joining, everybody. See you next month.
Hey, Gary, before you run away, did they end up posting the videos from PEI? Have they gone up yet, or is it just the presentations?
You know what? They are not posted, and I'm not quite sure whether they're going to check in with Jada.
No, that's cool. I just mentioned that at the start of the meeting, and I wasn't quite sure whether I knew they were coming potentially. Yep.
Yeah, and I forgot, so thank you.
That's all right. It's all good.
I think the answer is they're on the IRCP's Facebook page. We couldn't use
Yes, they are.
YouTube, which is our normal platform this year because we didn't have enough subscribers.
Yes.
But I think they're on the IRCP Facebook page, but they're in groupings by half day.
Yes, morning, afternoon, etc.
Yeah.
Yep. Cool. All right.
All right. Thanks, everybody. Thank you, Duncan.
You're welcome. See you, mate. Bye.
Bye now.